Good afternoon, everyone. On this World Hypertension Day, I welcome you all to this panel discussion. The theme is Checks and Balances, Heart of the Hypertension Solution. At the onset, I would thank Voice of Healthcare for providing us this platform to interact with our fellow practicing clinicians and the general public. We have today with us 4 prominent doctors from the field of cardiology and medicine as panelists for discussion. I welcome Dr. Nityanand Tripathi. He is the Director and Unit Head, Fortis Hospital, Shalimar Bagh, Delhi. Dr. Ranjan Shetty. He is the Head of Department and Consultant Intervention Cardiologist at Manipal Hospital. He is still to join with us. We have Dr. Avijit Bhattacharya. He is the Head of Department Medicine at AMRI Hospital, Kolkata. Dr. Sharath Reddy. He is Intervention Cardiologist at Medicover Hospital, Hyderabad. Welcome, everyone.
Thank you.
To start the discussion, welcome. To start the discussion, I would like to take you to the journey of the history of hypertension. The term essential hypertension was coined by Eberhard Frank in 1911. Hypertension was at that time classified into malignant and benign hypertension. In 1949, in the classic textbook Diseases of the Heart, Charles Friedberg stated benign hypertension defined as blood pressure up to 210 by 100 millimeter Hg need not be treated. So you see from that era, now in that era, his views were echoed by renowned professors and cardiologists throughout America and Europe. However, since the 1950s, longitudinal studies like the Framingham Heart Study concluded benign hypertension was not harmless. Hypertension across the whole spectrum is significantly linked to stroke, heart failure, heart attack, renal injury, dementia, vision loss. Over the years, medical fraternity has been trying to find out the optimal BP as to mitigate the bad effects of hypertension. Various agencies issue guidelines for hypertension and revise them as per new scientific evidence. I now invite Dr. Nityanand Tripathi to decode for us the latest guidelines, protocols, and compliances in hypertension. Dr. Nityanand Tripathi, sir, please.
Thank you, Dr. KALRA. I will be touching upon the hypertension is such an important topic, and almost 30 to 40% of our population is affected with it, and it has direct bearing with the cardiovascular outcome and mortality. This goes linearly. So there has been lots of guidelines almost from each body. I will be presenting with the ACC AHA guideline, which has came into 2018, and then we will compare with the other guidelines as well. What is the difference? There is minimal difference, almost essentially the same. I am sharing my screen. So as I told you that hypertension is also associated with a lot of concurrent diseases as well, which add to the hypertension, and they also add to the mortality and morbidity and cardiovascular diseases. Almost 15% of them were smokers, almost half of them were obese, almost 2/3 had hypercholesterolemia, and 1/3 were diabetic. Almost 1/5 of them had a coronary kidney disease. And if I talk about the modifiable risk factor, which we can modify along with the hypertension, which will help in reducing the incidence of hypertension as well as the bad effect of hypertension, that is the SCVD. So the modifiable risk factor is current cigarette smoking, or second-hand smoking, which can be easily controlled, diabetes mellitus, dyslipidemia, overweight, physical inactivity, and unhealthy diet. While there are fixed risk factors as well, like chronic kidney disease, family history, which cannot be controlled. So let's focus on the modifiable diseases. So what are the category of hypertension as per ACC/AHA guideline? This category of hypertension keep on varying depending on the guidelines. So ACC/AHA says normal BP is less than 120 by 80 millimeters of mercury. If it is 120 to 129, and the diastolic BP is less than 80, then it is elevated BP. It's still not an hypertension. But if BP goes from 120 to 139 and diastolic BP is 80 to 89, this is stage 1. And if it is more than 140 or systolic or more than 90 diastolic, then it becomes stage 2 hypertension. So this guideline classifies hypertension in normotensive, elevated BP, stage 1 and stage 2 only. So the prevalence of hypertension is huge. As I told you, the overall crude prevalence is almost half of the population reports more than 130 by 80 millimeters of mercury BP, and it is either self-reported or antihypertensive medications. And almost 32% of the population reports more than 140 by 90. That is when you increase 10 millimeters of mercury, the prevalence comes down to around 16% down. And when you see it sex-wise, men and women are almost equally affected. If we see age-wise, then as age goes on increasing, so is the hypertension incidence. As between 20 to 45, only 30% of the people has hypertension, while when it goes to 75 plus, it becomes 79%. Almost every fourth out of fifth person is hypertensive. So it is so important that as you go on along with the age, then hypertension keeps on increasing. So thinking that I am not hypertensive at this age, I won't develop in the next decade, it's erroneous. We should consistently check our BP so that whenever there is a development of hypertension, we can properly control it and check it. Race and ethnicity do have bearing. Non-Hispanic whites have lowest rate as non-Hispanic Asians, while Hispanic and non-Hispanic blacks has a high incidence of the BP. So first thing first, how to check whether you have a BP or not? That is most important thing. So properly first, don't walk in and take the BP, and that way BP is not reliable. So first step is properly prepare the patient, have patient relax, sitting on the chair, feet on the floor, and back resting. Patient should avoid caffeine, exercise, or smoking within 30 minutes, and ensure patient has emptied his bladder and bowel, because urine itself, full bladder itself can cause increase in the BP. Neither the patient nor the observer should talk for the 5 minutes. That's most important. And remove all clothing covering of the location of the cuff. So one should not take the BP above the cloth itself. Measurement made while patient is sitting or lying does not conform this criteria. So always take the BP in sitting positions. Second step is use proper technique for BP monitoring. Use BP measurement device that has been validated and ensure that device is calibrated periodically. We have seen in our practice that patients comes to us when hospital BP is 120 by 80 or 130 by 80. When he goes home, his BP is 160, 90, 160, 100 with the uncalibrated instrument. So that is also very important. And then support the patient arm so that it is at the level of the right atrium. Position the cuff in the middle, and lower part of the cuff should come at the elbow. So it should touch the elbow crease. Use the appropriate cuff size. I will tell you what is the appropriate cuff size. Either the stethoscope diaphragm or bell can be used for the auscultatory methods. And how to take a proper measurement needed for diagnosis. At first visit, record BP in both arms. Use arm which gives the higher BP. It's not the arm which gives the lower BP. That should be taken. It should be taken at the interval of 1 to 2 minutes. For auscultatory determination, use palpatory method for the radial pulse. Then use state. First appearance of coruscant sound is the systolic, and complete disappearance is the diastolic blood pressure. Properly document is accurate BP. That is most important. Ideally, in not uh, odd but in even numbers. Average reading, use the average reading of the two, obtained at more than 2 occasions, and provide patients with the systolic and diastolic reading both verbally and in written. That is also important. So, how to select the cuff? If arm size is small, then use 22 to 26 centimeter. In adults, use 27 to 34 centimeter. In large adult, use 35 to 44 centimeter cuff, and in adult thigh, use a huge cuff that is 45 to 52 centimeters. And this is for the office recording of the BP. And then how to record BP at the home and how to take BP at the home. I think we can take it later on once discussing how to monitor your BP at the home. And home monitoring, whether you are monitoring home monitoring BP or with the automatic BP monitoring, the results are almost similar from the office to the home. Only in the ABM, it is 5 millimeter mercury lower than the BP measurements taken at the office or at the home with the home monitoring system. So BP based on the office and out of office measurements, BP is divided into normotensive, sustained hypertension, masked hypertension, and white coat hypertension. This is very important. Normotensive is fine. So sustained hypertension is when you find BP in office setting and in home setting, both BPs are elevated. Then it is the sustained hypertension. Masked hypertension is when in office the BP is not elevated, but at home it is elevated. Reverse is the white coat hypertension. Person's BP is elevated at the office, but it is normal at the home. These are the also very important. So detecting the white coat hypertension and masked hypertension, if BP is more than 130 by 80 and less than 160 by 100. If it is more than 160 by 100, it is purely hypertension. Neither it is white coat hypertension nor it is masked hypertension. So if between 130 to 160, daytime ABM or home BP monitoring should be done. And if it consistently comes down to 130 by 80, that means it is white coat hypertension and only lifestyle modification and annual follow-up is required. While opposite is true with the masked hypertension. When you take the BP in the office, it is normal. When you take the BP at the home, it is higher. So in this case, continue lifestyle modification, and they need medications despite being normotensive at the office. That's the most important thing. These two things. White coat and masked hypertension in patients, drug therapy, how to screen it, as I have told you. If you consistently find it higher, then continue with the medication. Otherwise, continue with the lifestyle modification and regular follow-up. So, what is new onset or uncontrolled hypertension or secondary hypertension? One is essential hypertension, where we could not find the cause. Second one is the hypertension, where we can find a cause, treat it, and BP becomes normal. So only 10% of the cases have secondary hypertension, while rest of the persons are the essential hypertension. So how to suspect it? When there is a drug-resistant hypertension, abrupt onset of hypertension is there. Onset of hypertension below 30 years, exacerbation of the previously controlled hypertension, suddenly disproportionate target organ damage, if it is there. All of them points towards the secondary hypertension. That there can be a secondary hypertension. Screen for secondary hypertension. If positive screening, refer to the specialized clinic, or else continue yourself. So I will just briefly touch the most important causes of the secondary hypertension. They are the renal penile column hypertension, 1 to 2% of the cases, and it is because of the renal kidney disease, which should be treated and screened accordingly. Renovascular hypertension can happen in 5 to 34% of those 10% of the cases, and there can be a abdominal bruit, there can be bruit somewhere else as well. Do an renal Doppler study or MRI or abdominal CT, you will find the cause. So the primary aldosteronism is another common cause which happen in 8 to 20% of the cases. The most frequent cause which can be easily diagnosed in our population is obstructive sleep apnea, which is 25 to 50%. It contributes to the secondary hypertension and can easily be managed with the home treatment. And this should be wherever you suspect, it should be diagnosed and treated accordingly so that organ damage can be minimized and patient can be rehabilitated back to the normal life. Drug and alcohols can induce hypertension, and once while taking the history, it is very important to take the history of drug and alcohols like sodium containing antacid, caffeine, nicotine, alcohol, NSAID. There is a huge list of the substances which can lead to the hypertension, and but the important one is the decongestant and antacids, caffeine, which you usually use in our day to day as a coffee, brown chocolate and or black chocolates, and the lot of other agents as well. So less common causes, I think we can skip it because they are less frequently present, and it only when they are when it is suspected, then they can be uh, like investigated and diagnosed further. The frequent medications, I will again repeat, it is alcohol, amphetamines, antidepressants. Antidepressants can also cause hypertension. So if there is hypertension and patient is on antidepressant, please change it. It might help the patients in getting relief from the hypertension. Antipsychotic drugs, caffeines, and decongestant, usually used in our rhinitis and other uh, conditions. Herbal supplements, immunosuppressants, and oral contraceptives are the notable ones. So, best proven non-pharmacological intervention for prevention and treatment of the hypertension. So, I will just discuss this, and then we will continue with the further panelists. So, weight loss is very important. Weight loss leads to decrease in 5 millimeters of the mercury BP, and best goal is ideal body weight, but aim for at least 1 kg reduction in body weight for most adults who are overweight, except about 1 millimeter. It and expect 1 millimeter mercury decrease in the BP. Healthy diet, that is DASH diet, most commonly talked about, should be followed, and it has been found to decrease 11 millimeters of mercury of blood pressure. Reduce intake of dietary sodium, that is most important, and goal is to consume less than 1500 milligram per day, and is uh, enhance intake of the dietary potassium. Physical activity, whether aerobic, dynamic, resistant, isometric resistant exercises, all have shown to reduce the BP. So the exercise and physical activity plays a very important role not only in reducing the BP but also it reduces the cardiovascular mortality and morbidity as well. Moderation of alcohol is again important. If if ever drink is being allowed, it should be 1 to 2 drink per day for men and less than uh, one drink for the females. So basic optional laboratory test once you have diagnosed the BP is go for the fasting glucose, blood glucose, complete blood counts, lipid profile, sodium creatinine, serum sodium potassium, thyroid stimulating hormone, urine analysis, electrocardiogram. Optional testings are echocardiogram, uric acid, and the urinary creatinine ratio. So this is the overview of the guidelines. Uh, how to take the BP, what are the causes of BP, what is the extent of the BP. So, if Dr. Kalra permits, I can continue with that. I have already covered the non-pharmacological treatment, or else we can discuss the pharmacological treatment.
Thank you, sir. We have another session for the treatment part. Thanks for a very informative presentation. We would now go to the second session.
Thank you, sir.
Europe and USA are always at loggerheads when it comes to management of diseases. I invite Dr. Ranjan Shetty to highlight the areas of differences between European and American guidelines in the management of hypertension and their impact and application in the Indian subcontinent. Dr. Ranjan Shetty is Head of Department and Consultant Intervention Cardiologist at Manipal Hospital, Bangalore. Over to you, sir. Your mic is at mute.
Yeah. Thank you, Dr. KALRA, for that wonderful, for this opportunity. Yes. So I have no slides, so because it's a panel discussion, I thought we should all discuss and come to, a conclusion and how it affects our people. But you're right that the problem with the hypertension is that there are 2-3 things. One, hypertension is a bad disease and not a disease of harm like people think, and they neglect it all the time. It can be hidden. It can be, there are multiple entries where there is masked hypertension, and there is, there is office BP. Office means hospital BP. Home BP is the one which we are supposed to rely more and more. Now, what would these guidelines say? Because there have been too many guidelines, and most of us who have practiced for some time, from JNC4, you have seen ups and downs happening. Drug which are indicated becomes contraindicated, and the same drug comes back after. So it's always been confusing. What is also surprising is you have the same data. You have same trials, same this, but a different guideline emerge out of all this. So I'm going to talk about how to make sense of these guidelines rather than, dissect out these guidelines too much. How would I approach when the guideline change, and how would I manage my patient? One, going by American guideline actually wants to distinguish people with comorbidity and people without comorbidity. That's the basic difference there. So people without comorbidity, BP 140/90 is okay. Anybody with comorbidity, especially diabetes, IHD, 130/80 becomes ideal. Whereas Europeans, have always been little more ahead. So their cutoffs are always little lower than Americans, and it's been typically 130/80. So the key message which I want to, and then there are Indian societies which give guidelines, but most of all, it doesn't make sense when you have 100 guidelines and when we have to remember so many guidelines. So the key message, probably if I have to give one, so I would advise that if it is a hospital BP or an office BP, as we call it, the cutoff should be 140/90. For whatever reason, it's not going to be same as home reading. And if it is home BP, it has to be, home means it has to be now with ambulatory BP. The same electronic machine which we didn't like for a long time is now recommended. And now what we recommend is every person, like hypertensive, like a diabetic should have a glucometer, hypertensive should have a BP apparatus. It has to be at home. You have to test the way which I think Dr. Tripathi has beautifully explained how to test the BP at home. So please follow all those. You must have a BP apparatus. And at home, the cutoff will be 130/85. That means at hospital, when you come, the cutoff is 140/90. For obvious reasons, at home, the same cutoff should be 130/85. So these are the two numbers you should remember. Please don't remember 100 numbers, just not possible, and it's very confusing. Why the change? Because of the trials, the sprint trial which showed benefit, the J curve which we are always talking about may or may not exist. So because of all these trials, we realize that home BP using or so-called oscillometric device or automatic BP apparatus are more reliable, are more appropriate as far as daily, as far as events are concerned. So these are the two numbers you remember: 140/90 in hospital or office and 130/85 at home. Please don't remember any other number. Just stick to these two numbers. Ambulatory BP, whenever you have doubt, masked hypertension. 10% of hypertension are masked. For whatever reason, the hospital BP is lower and the home BP is higher. So there must be stress at home which is producing it, but the BP at home is higher. So typically, when do you suspect if you find LVH in ECG or echo? ECG, you see some LVH changes, but BP is always normal. Or most other people, you need to tell them to check BP at home using any of the standard validated machine. And if it is high, start treatment. And that's how we should probably go ahead. And the drugs for treatment also keep changing now and then. It's like fashion, it changes very, very often. So what we recommend today may not be true tomorrow, but all of us recommend what is most appropriate for the current era. So role for ambulatory BP is more when there are lots of fluctuation in BP. You see a erratic number, and I also use it to adjust the timing of therapy. There are people whose morning BP is fine, but 5 o'clock BP goes up. Do ambulatory BP, find out which BP is higher, and adjust your time. Sometimes it's just the timing of therapy which matters. People are already on drug, but it's just that little bit adjustment of timing from 7 to 1 o'clock. Add something during lunch. These are the things which really matter when we are managing hypertension. So if I have to just conclude by maybe adding 1 or 2 things, the third drug, the first drug need not be diuretic. The second drug need not be diuretic, but third drug has to be diuretic, because then there is so much of fluid retention which occurs because of drugs, and that has to be ideally a renally appropriate diuretic. That means for a normal renal function, it has to be thiazide diuretic, chlorthalidone being the preferred thiazide. For renal dysfunction, it will be torsemide or furosemide, which will be the renally appropriate. The fourth drug, by the time you reach fourth drug, you are already into what we call as resistant hypertension. That's the definition. Typically, at that time, it will be aldosterone antagonists which are added, because they are the best. So 2 entities are, one is resistant hypertension, second is refractory hypertension. By refractory definition is 5 drugs. There are 5 drugs and the BP doesn't get controlled. They typically have sympathetic, extra sympathetic activity. They are tachycardic. That's when beta blocker come. Now we know that beta blocker is never first line, no? So they are 4th or 5th line. That is what we call as refractory hypertension. So beyond this, I think it's good to have some discussion and chat and, see what we follow. Yeah. Thank you, Dr. KALRA.
Thank you, Dr. Ranjan, for this practical approach. No doubt, these ever-changing guidelines keep us confusing, not just the students, but the clinical practitioners also. Thanks for the practical approach. Coming to the next session. Historically, the treatment of hypertension started somewhere in 1950 when we had the first drug, thiazide, which was approved for the treatment. Since then, we have come a lot way. We had discovery of many other drugs like beta blockers in the 1960s. Then came the calcium channel blockers, and in 1977 we had the captopril with us. Since then, we have a lot of options for treatment of hypertension. I would invite Dr. Avijit Bhattacharya for the next talk. He would highlight the current, the newer trends in the treatment of hypertension. Over to you, sir.
Yeah, thanks, Dr. KALRA. I think Dr. Shetty has given a good overview of what we normally do when you get a new onset hypertension. And Dr. Tripathi has also given a view of what should we choose the later phases. Now, as Dr. Shetty has told that, whenever we have to give more than 2 drugs, it has to be a thiazide type diuretics. But these days, we do not prefer thiazide, but rather thiazide type diuretics. So, we prefer a chlorthalidone or inapamide because they are longer acting, and with a sort of the minimum, with a half dose of thiazide, you can achieve the blood pressure control better. So number one, a new approach is to choose a thiazide type diuretic instead of thiazide. And of course, these are the side effects of hypokalemia, and you have to check a potassium level maybe 10 to 14 days after you introduce the drug. So this is one thing which one should remember, that instead of classical thiazide, it's better to choose a thiazide type diuretic. And of course, when the question of resistant hypertension comes, we have to use a MRA type drug. Unless we have used MRA and exhausted the option of using MRA, we cannot really brand it as resistant hypertension. So initially, if your blood pressure is more than +10/20 of the advocated guideline, you can start with 2 drugs, maybe ACE inhibitor ARB with a calcium channel blocker. And the next choice should be a diuretic, which I've already told, thiazide type diuretics. And if it is not controlled by that, and if you are going into that resistant phase, the question of MRA comes. Now, beyond drug therapy, there are certain other issues which has also been briefly outlined by Dr. Tripathi. I think number one is to exclude OSA, which is a very important facet. And if you have a OSA phenotype and you have classical symptoms of OSA during daytime somnolence and snoring, as told by the partner, one should always go for a. Now, there are some simple tests like apnea link test, which is not as exhaustive as a classical PSG. So we can do that and rule out OSA, because that's a very important cause to be ruled out. And if you treat OSA, your hypertension can easily be controlled. And there are certain other things, telltale signs. If one should ideally rule out hypothyroidism. One should ideally rule out hyperparathyroidism, primary aldosteronism. These are there. And apart from drug therapy, the other important thing is to look at the diet, whether we are sticking to a low salt diet. Ideally, one should consume less than 2.4 grams of salt per day, and a high potassium diet by way of fruits. And the third is, of course, one is to, if one is a smoker, one should quit smoking. The next important thing is importance of exercise, which cannot be more than highlighted. And of course, if you consider, apart from drug and exercise and other ruling out other causes of secondary hypertension, other novel treatments which are there. Only yesterday, ACC conference has the paper of Reddy and solo HTN paper was published, where ultrasound guided renal denervation has been again brought out, where the earlier trials, Simplicity were not positive trials. This is supposed to be a positive trial. So these are the broad issues, apart from customized treatment for the hypertension, looking at diet, looking at exercise, looking at smoking, and choosing diuretic at a proper time. And of course, if everything fails, then of course the novel treatment in the form of renal nerve denervation comes. Thank you.
Thank you, Dr. Avijit, for a very crisp and practical approach towards the management of hypertension. In the year 2020-21, nothing can be concluded without talking about COVID-19 pandemic. I again invite Dr. Avijit Bhattacharya to highlight the relationship between COVID-19 and hypertension. Is hypertension a risk factor for COVID disease or severity? What is the optimal therapy for hypertension during COVID-19 illness? Dr. Avijit, sir, please.
Yeah, again, this is a very pertinent thing, because we all know that uncontrolled hypertension is a major risk factor for COVID morbidity and mortality. So, of course, the same algorithm for treating hypertension is valid. But the important thing is that we have a lot of asymptomatic, mildly symptomatic COVID patients who are treated at home. So I think for those, we have to emphasize on home blood pressure monitoring. And as Dr. Shetty has highlighted, that just like glucometer, an essential part of treatment of hypertension is to keeping a blood pressure machine at home. And of course, these days we rely more on the oscillometric or the automatic blood pressure machines. But we have to choose a good brand. And I think, for the patients who are being managed at home, the emphasizing about good blood pressure control at home is very, very important. And by that way, through online consultation with their physicians, they can have a checks and balances on hypertension. And if you have a good blood pressure control, like your good glycemic control, your risk for getting a COVID-related morbidity mortality becomes less. So it is not only the level of hypertension or diabetes, it depends on how much good control you have. So you have to emphasize to the patient and their relatives that even if you have hypertension, even if you have diabetes, you have to emphasize on control. And for control, you have to keep in touch with your physician. And if you have to measure blood pressure and measure your blood sugar at home. So that's the essence of treating. Of course, when one is hospitalized and one has a moderate or a severe disease, the blood pressure control comes in the realm of hospital-based practice. And depending on the situations, the doctors can choose. But the one thing is very important is that there is a controversy about using ACE inhibitors in the COVID patients, and that has been disproved. There has been no trial to prove that it is antagonistic and that has a negative effect. So if someone is already on ACE inhibitor or ARB, there is no reason to stop that, be it hospitalized patients, being at home care. Thank you.
Thank you, sir. With this, we conclude the first half of our World Hypertension Day panel discussion. I am sure the talks delivered by our expert panelists would have answered many queries of practicing clinicians and helped them manage their patients more effectively. The second half of today's program is focused more on the perspective of general population. We will try to address the questions that our patients ask us in our clinic practice regarding the management of hypertension. As a nephrologist, I always encourage my patients for home blood pressure monitoring. Home blood pressure monitoring has even become more relevant in this COVID pandemic times. I would invite Dr. Ranjan Shetty to highlight what are the indications for high blood pressure monitoring. What should be the frequency of high blood pressure monitoring at home, of home blood pressure monitoring?
Yes. Thank you, Dr. KALRA. Yes, home, I think all panelists and everybody agrees that home blood pressure monitoring is the only way forward. That means this is something which is essential. This is something which must be there. But once we do that, as I think Dr. KALRA was telling us, it becomes very important. People ask how many times, what time of the day should we take, how many times should we take. So the very important message is not too many times. If you do too many times, the act of measuring itself increases the BP. So it has to be optimal, but it should not be over. It should not be too many. So what I tell my patients when they have issue, when they are newly diagnosed, when they are on treatment is that initially try to measure every day, fix up a time. It could be 8 a.m., 8 p.m. But the time should be such that you're not too hungry, but you have not had your meal for half an hour, and you have not taken tea, coffee for half an hour, you have not exercised in the previous half an hour. So that is a time where you rest for 5 minutes or 10 minutes, take 2-3 ECGs, and after that 2-3 readings after 5 minutes with blood pressure. You want to remove the first blood pressure can be taken off, the second and third can be average, and that's your blood pressure. Also, what I advise them is to note their heart rate, because if they're too tachycardic, that indicates the anxiety element which is present there. So this is how we need to measure BP, but not too many. So first 1 or 2 weeks, you could do daily blood pressure measurement. That is the time when your doctor is adjusting your medicine. Also, what is important is no drug will act quickly. It does need 4 to 5 half cycle. That means most drugs need around 2 weeks to show their full effect. So don't be in a hurry. Don't panic. It's a gradual process. It's a marathon. It's not a 100-meter sprint. So it has to be gradual. It has to be gradual reduction of BP. And over the time, you reach every 2 weeks is when you need to review. Once your blood pressure is reasonably under control, once a week measurement is enough. Don't do too many times again. Once a week is enough.
Thank you, Dr. Ranjan. Yeah. I would invite Dr. Sharath Reddy to throw light on the following questions. What is a better method of home blood pressure monitoring? auscultatory or automatic electronic devices, what to choose, whether a wrist device is better or an upper arm cuff device. How do I know whether the automated device that I'm using is good one? What is the exact cuff size I should be using? Dr. Reddy, please.
Yeah, thank you, Dr. Deepak. Couple of things already Dr. Ranjan covered, in last question. I'll add one thing to what Dr. Ranjan has mentioned about number of readings. Yeah, too many readings are not good, but at least minimum 2 readings is mandatory for a decision making for a physician. And timing also, it's better to maintain same time every day. And minimum duration of monitoring should be at least 4 days to 7 days. 7 days is recommended, but at least 4 days is mandatory. So minimum 2 readings per day. And every time you always take 3 readings. As Dr. Ranjan mentioned, remove the first reading and take the average of second and third reading. And 4 days and overall 7 days. So that is a typical home blood pressure monitoring regimen. And coming to which device to use, see, most of the data showed there was an analysis done with many devices, and the study showed only 30% of the devices available right now were adequate or comparable with your sphygmomanometry. So, I mean, even this has clearly mentioned which devices are more better. And what I use typically in my practice is it's an arm cuff, not wrist devices. So wrist devices I use only when patient is too obese and when I think his arm cuff is not sufficient enough to give appropriate reading. That's the only patient where we use wrist. Otherwise, wrist monitoring devices are not advisable. So it's an arm cuff, and either semi-automated or fully automated is fully okay. So anything is fine. And if you have oscillometric device, yes, it is. I mean, the reason that data is coming out, these devices, oscillometric methods, that neutralizes even cuff malplacement, effect on blood pressure. So if that is available, it's fine, or otherwise, whatever is available can be used. And the length of cuffs, I'm not clear, how many types of cuffs are given to each patient. See, most often, at least here, we don't get too many options available for patients. I think most of the time there are only 2 cuffs available with us. So as far as the cuff is concerned, it is very, very important. I think we have to optimize the cuff size to each patient. At least patients who are very obese, where we think the regular cuff may not be sufficient, it is better not to do this home monitoring with this device. You can advise wrist devices. I think that's all. Anything else, Dr. Deepak, which you wanted to add?
Thank you, Dr. Sharath. Yes, I think you have answered all the questions. Hypertension is the #1 contributing risk factor for global death, causing strokes, heart attack, and renal failure. More than 10 million lives are lost each year unnecessarily due to raised blood pressure. These deaths are preventable. Hypertension among general public is highly underrated disease, and people don't pay attention to high blood pressure. I would invite all the panelists to suggest how we can help overcome this problem of among the general public and raise awareness among the general public. Dr. Nityanand, please, would you like to comment?
Yeah, I think most important thing is awareness. So, as a medical community in India, we have been creating awareness among the population, but awareness has to be multi-pronged. The media, the medical fraternity, the government, everyone should come and make the people aware that, see, the BP is not going to produce symptoms most of the times. It's a silent killer. So we have to screen our population at every opportunity that we give, that we find. Like whenever they are coming for anything in the hospital, there can be chaos at the railway stations and hospitals where people can put a coin, get a BP, so that whenever their BP is higher, they can come to the contact with the medical fraternity and get a appropriate diagnosis and treatment. So I think the awareness, education, and facility to each, which can be easily approached for measuring the BP, and is most important thing in uncovering the BP where it is not diagnosed. And we have to again emphasize that as the age grows, the chances of becoming hypertensive becomes more and more and more. So if you are not hypertensive this year, 10 years after, one might become hypertensive. So I think education and screening is the most important.
Yes, definitely. There is a lot of myth between among people. I see elderly people that they always say my blood pressure of 160 is appropriate for my age. I do not take any medicines for it. If I lower it, probably it will cause more problems. Such myths are very prevalent in our society. And definitely it is our duty that we have to increase the awareness among the general population about the exact diagnosis of hypertension. In spite of so many drugs, very less expensive drugs are easily available, we miss the diagnosis of hypertension, and it leads to so many incidences of strokes and CVA. Dr. Sharath Reddy, would you like to please add a comment?
Yeah. So as Dr. Nityanand mentioned, hypertension is described as silent killer in epidemiological, descriptions. And the epidemiological data also says this rule of 10, or the tip of the iceberg phenomena when it comes to hypertension, prevalence versus the diagnosed people. So the diagnosed people are like tip of the iceberg, and again in diagnosed people, so how many people are compliant to therapy? So another tip of the iceberg. So again, in people who are compliant to therapy, how many people's blood pressure is under control? It's another 10%, that is tip of the iceberg. So if you analyze, so the awareness is needed at different levels. The level one is basically bringing all these missed people who are not diagnosed yet. So for these people, so we need to act at community level. So community level periodic screening, community level education, using media, social media, or print media, or television media. So that is something which may really help, along with periodic community level screening by using our primary healthcare personnel. So that is where we can increase, we can address the first tip. Now you can diagnose more and more people. And once patients are diagnosed, next comes the treating them adequately and achieving goal blood pressure for every patient. Because again, here even diagnosed patients who are compliant to therapy is also another tip of the iceberg. So here comes education by physician. Physician who is diagnosing the patient has to create a education around this hypertension and the need for management of that hypertension. We have to tell certain things straight to the patient. See, this is a silent killer, and you have to take treatment. Treating hypertension is like taking an insurance policy. If you get treatment from today, we are going to prevent complications after 5 to 10 years. That is the end organ damage. So these are the certain things which we have to educate patient, and also we have to educate patient about the goal level. See, what is the goal of therapy or medication. So he has to take medication regularly to keep his blood pressure below the goal level. That could be 130/80 or 140/90 based on the patient comorbid condition. So that till we achieve goal level, he has to come for periodic follow-ups. That could be once in 2 weeks. So once medication is titrated, and then patient can have periodic checkups once in 4 to 6 months with a periodic home blood pressure monitoring once in 4 to 6 months. So to create awareness at community level for people who are not diagnosed, to diagnose, and also once diagnosed, to make people stick to therapy and stick to the goal blood pressure with a periodic home blood pressure monitoring. It's basically creating education around it by people at primary healthcare level and people who are diagnosing, sitting in clinics. Both has to work hand in hand. Then only we can raise, awareness, and also we can reduce end organ damage due to hypertension in most of our patients.
Dr. Ranjan Shetty, please, would you like to add a comment?
Yeah, thank you, Dr. KALRA. I think the previous two speakers have got a very valid point and something to think about. This disease, see, the problem is we always say India is diabetic capital. But if you look at epidemiology and population prevalence, there will be double hypertensives than diabetic. Yes. With diabetic capital, it will be twice. The hypertension capital will become twice. Because people might escape diabetes because they are not genetically susceptible. But chance of anyone escaping hypertension is small. That means by age of 50, 55, 90% of the population becomes hypertensive. So that's where I think our communication with patients comes in play. This disease is neglected by patients as well as by physicians, actually. When people come, when we have a high BP, sometimes we also don't take it seriously. Patient also generally gives a big explanation why the BP is high. I came running, I came rushing, and no time and things like that. We accept it most of the time. So this is something where we need to sit with them, make them understand it. Being hypertensive is not bad because majority will become hypertensive in time to come. Some would have become at 30, some will become at 50, most will become by 70, 60, 70. It's something which will happen. And next step is, as I think my Dr. Reddy was also trying to tell, that medicines are not your enemy here. You need to tell them the outcome. It's not about taking medicine or not taking medicine. It's not about side effect of the medicine. It is what disease can produce. There, I think everybody understands. There is a stroke, patient has hypertension. Everybody accepts this. There is no issue. Heart failure, hypertension, CKD hypertension is acceptable. We need to tell them that it is this hypertension which leads to all that. It's very important for us to connect the dot, take patients in confidence, make them understand that instead of taking your calcium tablets and B complex, with those so willingly take, it's more important to take your BP tablets and get the BP under control. Look at the bigger picture. It's about preventing so many complications. See, 80% of the stroke are actually attributable to hypertension. So is heart failure. For MI and other diseases, the attributable risk is lesser. But here, these two diseases, the attributable risk is 80%. That means if you control this, you'll hardly see a stroke without hypertension. So it's very, very important that people understand it is this one which leads. Make sure if you need treatment, take. If you want to try lifestyle, welcome, you try. Does work, but then come back. It's not that lifestyle and go away. After a month, come back to us. We recheck your BP. We are happy if you don't need medicine. But if you need medicine, please take it. Don't ask about side effects. Please take it and make sure the blood pressure is controlled. And again, as I think Dr. Reddy clearly said, it's not about taking. Once you take, BP has to be controlled. You may have to come for more visits to us and make sure the BP is adequately controlled.
Thank you, Dr. Ranjan. Our discussion today was aimed at raising awareness about the easily identifiable and treatable disease. I hope we have contributed to the cause. This brings us to the end of the session. I thank all the panelists for sparing their valuable time and highlighting the management of hypertension. I thank Voice of Healthcare for organizing the panel discussion. I conclude by saying, measure your BP accurately, control blood pressure, live long. Thank you.
Thank you.
Thank you.
Bye.